Hello, everybody. Welcome to RBH's webinar series. I appreciate you attending. We have with us today Dr. Esparza, Medical Director at Cedar Hills Hospital. We appreciate him coming. Dr. Esparza is a frequent contributor to our knowledge base here for our clinicians, so we appreciate having you here today.
Thank you so much. So as mentioned, I'm Dr. Esparza. I'm a board-certified psychiatrist, also board-certified as an addiction medicine physician, and board-certified as a medical review officer, also serving as a substance abuse professional. I'm the medical director of Cedar Hills Hospital, in addition to Bridgetown Recovery Mental Health Services. So the goal today is to keep things fairly simple. I want to make sure that folks are able to digest this information. I may get a little sciencey and a little bit off target at times, but we'll try to keep things fairly simple and user-friendly. So the goal of this is to sort of discuss some of the morbidity and mortality associated with prescription drug use. I'm going to have a strong emphasis or focus on the use of opiates, since this is our most prevalent problem, in addition to the significant mortality and workplace involvement that this involves. So with that said, you advance this slide. I'll just do this guy as well. Okay. So it's important to know that folks who are substance users, whether it's prescription opiates used legally or illegally, they are employed. The majority of patients who are substance dependents or substance abusers, 70% of those folks are able to hold down jobs, of which the majority are full-time workers. So they are in our presence, so we need to be very aware of them. In addition, it really depends on the industry. Obviously, the food service industry, construction, extraction, et cetera, this is the most prevalent population. There's a high degree, 17% substance users within this population. But it's important to understand that regardless of the industry, this is not protective. This is not socioeconomic. This is not educational. Those things do perhaps reduce substance abuse percentages, but by no means do we want to fall into the category we think that these are professional folks, these folks have together, they're not substance users, because they are. There's a lot of folks that are using out there. The same data applies to the use of alcohol. It's mirror data. So with that said, we'll discuss the cost of addiction. So there's an estimated $81 billion loss for folks that are impaired on their positions. And it's important to understand that this is both direct and indirect cost. And sometimes it's really hard to identify and quantify how an employer may be losing money based on impaired folks. A lot of this is going to be individuals or employees who are intoxicated on the job. This could also be folks who are undergoing substance withdrawal. For example, let's say they're addicted to either a benzodiazepine or perhaps an opiate, and they cannot get medications that morning. So they're going to be, obviously their ability to work and to be functional and to be efficient is going to decrease dramatically. So there's a whole range: intoxication, withdrawal, etc. And looking at some of the areas that substance abuse affect, we're looking at inconsistent work quality, poor concentration, lack of focus, productivity, erratic work patterns, missing work quite frequently, and oftentimes having very poor excuses as to why they cannot be there and perform their job, mistakes on the job, in addition to accidents that happen to either the employee themselves, they're intoxicated, they're withdrawing, they're not at 100% ability to perform their job, they hurt themselves, or God forbid, they hurt somebody else on the job as well. In addition to sort of, early extended lunches, missed punches, early departures, and once again, just having, poor performance and often being quite absent. It is important to understand that also increased job performance, or specifically if we're looking at job accidents, either to the individual who's impaired or to their coworkers, translates to a lot of workers' comp, a lot of cost that is accrued by these individuals hurting themselves during periods of intoxication or withdrawal. In addition, this will translate to increased FMLA, time off, and having the cost of having to replace absent employees. So their workplace behavior is obviously going to be a concern. They're going to be avoiding work, have difficulty collaborating with other employees, blaming other folks for work-related issues, their hygiene, their personal appearance is off, excuses, poorly defined, increased family problems, etc. So this is an important piece that, for me, sort of changed the way that I perceive psychiatry. I initially went into psychiatry, well, initially I should rewind a little bit. I went into medical school with the idea of becoming a surgeon. eventually sort of looked at the unmet need of psychiatric patients, became a psychiatrist. And the more I become involved in psychiatry, I really understand the comorbidities between substance use disorders and psychiatric issues. And so at this point, it's quite difficult to tell what came first. Is this a psych patient that has a chemical dependency problem, or vice versa? Or is this problem simply the intoxication and withdrawal, is that creating a psychiatric illness? Because we have substance-induced mood disorders, substance-induced anxiety disorders, we have psychosis secondary to the use of substances. It's kind of hard to determine, is this person truly have a psychiatric issue or a chemical dependency issue? And this next slide is just sort of emphasizing that, is that there's a high comorbidity between anxiety disorders and substance use disorders, also mood disorders as well. These percentages are actually fairly low. For example, if you look at the anxiety data, it's like 20–30% of folks with an anxiety disorder also have a comorbid substance abuse disorder. The reality is, in practice, we see almost 70%. So if a patient initially shows up with an anxiety disorder, whether it's a simple phobia, whether it's generalized anxiety disorder, or a panic disorder, the comorbidity is often 70% between substance use disorders and anxiety disorders. It's important to understand, too, that from a genetic standpoint, these are very inherited disorders. Psychiatric disorders, substance use disorders are inherited, more so than anything in medicine. If we look at diabetes, if we look at cancer, those pale in comparison to the genetic predisposition that's passed on to family members. And also, this is not data, but this is my impression of how this works. I think from an evolutionary standpoint, individuals that had the ability to either obtain resources or were able to procreate, were able to pass on their genetic material. So I tell my patients all the time, I said, listen, from a genetic standpoint, you're highly evolved, you're a master resource gatherer. The problem is you're gathering the wrong resources. But these are very, very heavily passed through the genetics. So what are some of the common classes of medications of prescription drug abuse? So opiates, which are most prevalent, the painkillers, benzodiazepines, tranquilizers. In addition to that class, there is, and we'll talk about these in just a second, there's also the hypnotic medications. The hypnotics are your Ambiens, Lunestas, Sonatas, etc., in addition to the use of stimulants. So the prevalence of abused drugs is through the roof. 2010, 8.76 million people are abusing prescribed medications. Majority fall into three categories. Obviously, the painkillers are the primary with 5.1 million patients or individuals using these medications in the community. Tranquilizers or benzodiazepines at 2.2 million, and then finally stimulants are down at 1.1 million people are out there using them at this time. So some of the common opiates we're looking at are codeine, methadone, morphine, oxycodone, Vicodin, Percocet, fentanyl, and heroin. And it's important to understand as well, and I'm deviating just a little bit here, but it's important to understand that the majority of your patients start off using medications responsibly. For example, somebody has a surgery, they have an injury, so they take these medications as prescribed. And we see this on a daily basis. It's a very sad and unfortunate situation because with these medications, you naturally are going to see tolerance. People are going to need more and more medication to receive the same analgesic effect. With that said, individuals are taking higher and higher doses of these medications, which ultimately is a red flag to their prescriber because they'll see these individuals as potentially abusing medications and then fire them. So these folks have too many early refills and then they're gone. And so we see folks now who took medications initially responsibly for all the right reasons are using medications illegally. They're purchasing narcotics off the street, and a good number of folks will actually transition into heroin or methadone. And these are folks, these are professionals. These are doctors, lawyers. You'd be very surprised the population that I treat who is heroin dependent. The issue is oftentimes the person that sells you the oxycodone is also the person that sells you the heroin. And if, for example, their supplies are low and they don't have your traditional opiates, they'll say, listen, I've got heroin. If you're sick, this will get you well. And so individuals will do anything to avoid detoxification from opiates, which is a very, very uncomfortable physiological state. And so you'll find professionals who you would very much not expect doing heroin on a daily basis just to stay well. So it's important to know that, and I'll give you some scary data here, but it's important to understand that opiates are very much overprescribed. This is an epidemic in our society. It's also important to understand that opiates are not for everyone. I think, honestly, I think this is something that's been created in our society where folks marinate on opiates for extended periods of time. In other countries, if somebody's injured, there's a short course of these analgesic medications, and then they're gone. Other countries don't just let it go for months and months and months. And it doesn't matter who you are. For example, if you compare opiate addiction to alcohol addiction, 10% of folks who are out there have an alcohol issue, whether it's abuse or dependence. So if you think about 10% of our general population and looking at the prevalence of alcohol, how it's marketed, you can buy it anywhere, that's pretty amazing that it's only really 1 in 10 that truly develops some form of a problem. The reality is I would say probably 90% of folks who are exposed to opiates for a prolonged period of time are going to become physiologically dependent to opiates. So this is a very, very, very dangerous class of medications. So I've used this slide before in these lectures, but this is kind of an interesting case. And this is just sort of a call to the importance of regulation of opiates in our country. So looking at this is a true story. So this is a doctor over in Florida. In Florida, unfortunately, I'm not sure if they still do this, but they used to have the situation where the doctor could also run a pharmacy. And so he could prescribe oxycodone. He says, listen, I need you to go over to my pharmacy, get this medication filled, go right next door. And so the doctor is sort of getting paid on both ends. So there was a DEA sting, and they went into this office with this physician. They said, listen, the guy came in, he goes, I've got chronic back problems. I've had them for my entire life. I'm in an incredible amount of pain. I brought my own films in, so I want you to review my films, and perhaps we can talk about getting me on some sort of pain medication. So the guy brings in his films. The doctor throws this film up on his board, takes a look at it, and he says, well, clearly, you've got some issues. I mean, he goes, look at your hips. There's some dysplasia in your hips. There's some degeneration of your cartilage in your spine. You must be in an excruciating amount of pain. So he gave this gentleman a 90-day supply of oxycodone, who was a DEA officer. The DEA officer came back about an hour later with a couple of his coworkers and said, listen, you just read an x-ray of a dog. Because you can clearly see the tail of the dog all the way down the spine. And the sad thing is, or the funny thing is, this is actually a healthy dog as well. And so there's really a need to regulate this and get folks prescribing responsibly for the right reason. I mean, folks should have comprehensive medical workups before they receive opiates. You can't just bring in your own films to a doctor and expect to get a refill of medications. So with that said, the concerning data is that prescription opiate overdose. This is not heroin. This is not other non-synthetics that you could purchase, but this is prescription opiates coming from doctors are the #1 killer in our country. The concerning data is if you put everything together, if you put together all the deaths from heroin, from cocaine, from alcohol, in addition to talk about homicides, car crashes, all of this data, if you pull all those numbers together, more folks are dying out there from prescription opiates. So those things that are the scripts that are written by the doctors is the #1 reason that our patients are dying. So prescriptions for opiates is skyrocketed. 40 million scripts were written in 1991. In 2007, there was 180 million prescriptions for opiates that were written. In the U.S., it's important to understand that we are the biggest consumer of opiates on the planet. We are 5%. This is the shocking data. We're 5% of the global population, yet we consume 75% of the world's opiates. And 99% of the world's Vicodin or hydrocodone we're consuming as well, and 71% of oxycodone. Now, as I mentioned earlier, I think this is just sort of this is just a very odd situation that's been created in our country because of providers that say, listen, my patient's in pain, he needs pain medications. They can continue to prescribe again and again. Other countries don't have this, so they don't have these kind of problems. And you think that we would be learning from our mistakes, but the reality is that unfortunately the number of scripts are actually increasing too. In 2010, there were 210 million prescriptions written for opiates, whether that's oxycodone, Vicodin, etc. So if you were to stack those scripts up, you'd probably come pretty close to filling up the rose garden. So an amazing amount of medications are prescribed. Another concerning piece of data, in 2005, there were enough opiates prescribed by physicians in our country that every single person in our population, age, from an infant to 99 years of age, at one point in time could have had a 3-month supply in their pocket. So every single individual in our population could be on opiates based on the number of scripts that are written by doctors. So currently the World Health Organization estimates 2 million individuals in the United States are currently addicted to prescription opiates, and this number is increasing. An estimated 52 million individuals have prescription drug use issues and are using narcotic medications or opiates for non-medical reasons. Experimentation is beginning, or not beginning I should say, but high school students, 1 in 12 have used an opiate for non-medical issues within the last year. This is concerning because as a provider of addiction medicine, often the story that you hear is a lot of individuals, actually kids will find, and this is the concern, they find opiates to be safer than traditional drugs, even safer than cannabis. They say this is a medication that's prescribed by doctors that must be safe. And so they end up raiding their parents' in their parents' bathroom, get a hold of these medications, and 1 in 12 has a problem. We talked about the fact that about 90% of individuals with prolonged exposure to opiates are going to be addicted. We have a whole new population of kids that are coming up. And as we know, as addiction providers, this is often the most difficult population to treat, just because there's been a lifetime exposure, and their exposure began at an early age. So with respect to OxyContin, approximately 1 in 20 high school seniors are reporting that they use or abuse oxycodone, or OxyContin, I apologize. So looking at the prevalence of opiates, the question is, how do we get in this problem? Why are, despite the fact that doctors have a clear understanding that we are overprescribed, why do the number of scripts continue to increase? As I was mentioning earlier, I think that a lot of it is secondary to reduced provider time, as we find that the patient visit time is crunched down to 8 minutes, 15 minutes, et cetera. The provider wants to do something in-house right then. If a patient comes in with complaints of pain and they don't have time to physically work it up, oftentimes they will write a script for this patient in order to increase patient satisfaction and the whole idea of wanting to do right by the patient. Another reason, and this is interesting, I'll get into this a little bit in a while, but there's something called opiate-induced hyperalgesia, which is a paradoxical response. What that is individuals, and this is sort of my evolutionary sort of framework on why I think this happens. I think that we need to know when we're in pain. The body needs to know when it's in pain. When a caveman steps in the fire, he needs to understand that his foot's in the fire and he needs to get out of there immediately. What happens is you clog up all of your opiate receptors. All of your nociceptors or pain receptors are now filled by opiates. What's the body going to do? It's going to create more receptors because it needs to know, okay, for some reason you're clogging up the system, but we need to be able to keep ourselves safe. I need to know when I'm in danger, when I'm in harm, and so you get something called upregulation of pain receptors. With upregulation of pain, now people feel more pain. So whatever number of nociceptors or pain receptors you and I may have, these individuals who are opiate dependent are oftentimes have 3 times, 4 times the number of receptors. So they're exquisitely primed for pain. So paradoxically, as you go higher and higher on opiates, the pain is getting worse. And so we treat individuals all the time for chronic pain issues when they come in the hospital. Interestingly enough, as you reduce their narcotic load, their pain goes down. And so these patients are tenaciously hanging onto their opiates. They walk in the hospital and they say, listen, if you take these things away, I'm going to fall apart. It's going to be a mess. My pain will be unmanageable. But you get them to the point where their pain is actually going down with a reduction of opiates, and that's because you're getting now a downregulation of those pain receptors. What comes up can come back down. And also just finally, the reason we perpetuate overprescribing of opiates is the lack of provider education in the field of addiction medicine. When I completed medical school, I started in 1998, finished 4 years later, there was no addiction training whatsoever. In psychiatry, we have a rotation in addiction medicine. It's maybe 2 months. So it's some exposure, but that's about it. I mean, obviously, I assume that the curriculum has changed since I've graduated, and I'm sure there's quite a bit of education regarding addiction medicine. But the unfortunate reality is there's just not a lot of providers out there. Statistically, there's 1,700 providers of addiction medicine. They're currently treating 3.2 million patients. So this is a grossly underserved area of medicine. And given the fact that it's the #1 cause of death in our country and our doctors are not trained on how to treat it, it's a very substantial concern. So now we're going to talk about workplace impairment and how do you recognize if your coworkers are impaired. This guy's pretty easy to pick out of the crowd, but sometimes the presentation can be more subtle. I have seen this, though, in impaired employees at work. I don't know if you folks have, but this is not an uncommon presentation. So this would be nodding out. So recognizing opiates. I think this is important for HR folks, for employers, but also for coworkers as well. How do you know if the guy next to you potentially is on substances? We talked about statistically the risk of injury goes up if your coworker is impaired. So if someone is currently on opiates, if they've taken opiates, they're going to have pinpoint pupils. They're going to be slacky and droopy in their muscles. As you saw, they were nodding out. So mid-sentence, these folks can stop talking and just simply look as if they're falling asleep, but they'll respond quite quickly. Itching their skin and speech may be slurred in these individuals as well. So recognizing opiate withdrawal, these individuals have a dysphoric mood, nausea, vomiting, muscle aches, lacrimation, runny nose, pupillary dilation. So those pinpoint pupils that you saw before are exactly the opposite. These folks are going to have completely blown out pupils. They're going to be sweating, they're going to be yawning, and they're going to have insomnia and just feel very disorganized at work. So this is an important slide. This is a really good takeaway message. So we're talking about positive and negative reinforcement of substance use in addition to allostasis. So breaking that down, if you look at mood, there's that at the top graph, there's a flat line, and obviously there's a positive and negative graph there. So the regulated mood, if someone first starts using opiates, let's talk about it, even if it's, let's say the pain is now resolved and individuals continue to use opiates, or they don't have a pain disorder and simply start using medications recreationally, they're going to have positive reinforcement. They're going to feel better. They're going to feel euphoric. They're going to feel on their game. They're going to feel productive. Everything is fine. They're feeling wonderful. In fact, and this is oftentimes where folks, in my practice at least, get stuck on pain medications, is narcotics have a tendency, or opiates have a tendency, to fill in all the little gaps in your life. So for example, if you don't like your job, if you're not happy with your relationship, if you have an anxiety disorder, if there's something that you find distressful, you don't want to avoid, you don't want to confront, oftentimes opiates will fill those cracks up. And so folks marinate on opiates for prolonged periods of time. At one point, or at some point, and it's, each person's going to be a little bit different, but each person who's physically dependent or physiologically dependent on opiates is going to say, listen, it's not fun anymore. It went from recreational to me enjoying it, to getting a high, to getting a sort of a warm buzz and stuff, to now I'm just sick. So now there is no joy whatsoever. I'm just trying to I'm just working on the negative, trying to resolve the negative reinforcement. I just don't want to be sick. And that's the only reason that I'm using. So that it's created because there's something called allostasis. And allostasis is an inability to reach homeostasis. So these individuals cannot ever feel normal. They cannot reach a normal mood state. And so they're constantly chipping away at opiates throughout, trying to get well. Right? When you hear someone who's a heroin addict says, I'm just trying to get well, that's all this population is trying to do as well. There's no joy, there's no euphoria, there's just keep the sickness at bay, because the withdrawal from opiates is brutal. Folks are in bed, they can't get out, they have nausea, they have vomiting, they have sweating, they just feel god-awful. That's what makes it so difficult to get off of opiates, because if someone is to quit cold turkey off of opiates, they say, listen, I'm putting my pills down, I'm putting down my heroin, I'm done, I want to get better and I want to change. The chance of recovery from simply cessation of use is 3%. And so the odds are dismal. So these individuals relapse again and again, and every single time they use, it chips away a little bit of their self-esteem. It chips away a little bit at their motivation. In addition to that, their family members who trust them, love them, and want to see them do right start to lose confidence. They say, you're never going to make it. Look at that. I've trusted you so many times, and here we go again. And so it's important to understand that these folks, it's not a behavioral issue. This is a physiological issue. What it may have started off as behavioral now has changed. These individuals are simply trying to get well. And with that said, that kind of comes full circle with the conversation I had about finding individuals who are using drugs that you'd never expect. Well, for example, I had a doctor that's treating the other day who was a heroin user. He was muscling heroin on a daily basis. And he said, I could never see, just retired several years ago, but he said, I could never see myself as a doc shooting heroin every single day to not get sick. But these folks do things that they're not ego congruent. This is not something that's just okay with them, but they are simply just trying to get well and trying to keep the detox at bay. So the solution when we're discussing opiates is improving education about how highly addictive these medications are. I think that it's out there quite a bit in the literature, but I never think that it's talked about enough. And folks really need to be aware of the fact that they're sort of dancing with the devil when they start messing with these medications. And also question the necessity of narcotics. Do folks really need to be on medication? Because we talked about the upregulation of receptors. We talked about opiate-induced hyperalgesia. Are these medications truly necessary? And that's a question that should be asked of the patient, but I think also family members as well should be asking the doctor, You know, my wife's been here for 2 months. What are we doing with these narcotics? Why are we continuing to prescribe these medications? Are these necessary or not? Finally, they're improving the regulation standards for Schedule II medication. This was just a recent move. Vicodin was Schedule III, and so you could call it in on the phone. You don't even need to see your patient. And so you could give somebody a 3 or 4 month supply. You don't even need to see them. And so thankfully, they bumped Vicodin back into Schedule II, and so folks need to be seen more often. The argument I've heard from physicians before, some ER physicians, have said, listen, you know, this doesn't fit into quality of life. This person shouldn't have to come in every 2 to 3 weeks. We know they got pain. We're very concerned about them. So if you're so concerned, maybe you should see them more frequently instead of every 3 or 4 months, right? Improving funding and trading or training, it should be, in addiction treatment. As I said before, 17,000 providers treating 32 million patients. And then just figuring out alternative modalities for pain. Oftentimes, we just need to come to terms with the fact that there's not going to be a complete resolution of your pain. If you have chronic pain issues, that's okay, right? Obviously, you cannot expect 100% removal of that. So this is an important piece to discuss. When we're talking about drug testing for our patients, or most importantly, I should say in this case, in our employees, whether it's a pre-screening or whether this is a random drug test, oftentimes you're going to miss it. So the DOT standard is a NIDA-5 panel, of which opiates are one of the drugs that we're screening for. It only picks up codeine, methadone, and heroin. So if you have folks who are on semi-synthetics like Percocet, Vicodin, oxycodones, they're not going to show up. And so this individual says, listen, I'm not addicted to opiates, and they'll give you a negative drug screen for opiates. But so it's very important to do, if there's a concern about impairment, now that we all understand what the signs of intoxication look like with pinpoint pupils, right, with nodding out, with slurring speech, and also what does it look like when they're withdrawing, with dilated pupils, with runny nose, runny eyes, etc. Maybe do an extended panel on these folks, because you don't want to miss folks who are truly taking opiates. The next class of medications are benzos and hypnotics, and it's important to understand that these are medications that can kill you. If you come off of benzos, if you come off of hypnotics at high doses, you can actually die from these things. These medications are tranquilizers, and coming off of them, there's a balance between, and I don't want to get too nerdy here, too technical, but there's a balance between 2 neurotransmitters. One's called GABA and one's called glutamate. And so GABA is a neurotransmitter that naturally calms us down. Benzodiazepines, hypnotics, and alcohol are all GABA. And so the more that you ingest of these things, the less your body produces. It's kind of like a factor that says, listen, why am I making a product that you're dropping off for free every single day? It doesn't make any sense. So with that said, your natural ability to self-soothe is taken away. GABA and glutamate is on a teeter-totter, these two neurotransmitters working back and forth. Glutamate is an excitotoxic neurotransmitter. People who have epilepsy have high levels of glutamate. That's why they have seizures. And so coming off of benzodiazepines, individuals have seizures. They can die. It's a very, very high concern. With benzodiazepines, patients will tell you all day long that they're dying, but the reality is they're not dying. They're just praying for death because they're so physically uncomfortable. But with the benzos, you can actually, you can have a heart attack, you can have a stroke, and you can die. Some of the common benzos we're looking at are Xanax, Ativan, Klonopin, Valium, Librium. The hypnotics, like we said before, are going to be Ambien, Lunesta, and Sonata. It's also important to understand that the correlation between two different pieces, the correlation between half-life and addiction. So medications, whether it's a benzodiazepine or whether it's an opiate, the shorter the half-life, the more addictive the medication. So Xanax is obvious. I've layered these medications. Xanax is the shortest half-life and by far the most addictive medication that we have of the benzodiazepines, with Librium having the longest half-life and the least addictive, but it also is very addictive. It's also important to understand that 80%, and this is a shocking fact, 80% of all psychiatric medications are not prescribed by psychiatrists. And so these medications, Xanax, Ativan, Klonopin, et cetera, they're not coming from psychiatrists. Some psych docs will use these, but we're trying to figure out alternative modalities, perhaps an SSRI, even better, psychotherapy, teaching people to sort of deal with life on life's terms and to self-regulate, to tolerate their anxiety, et cetera. So these medications are out there. There's two endpoints when someone is physiologically dependent on opiates, and those 2 points are recurrence of anxiety or rebound of anxiety. Recurrence of anxiety means when you stop taking the benzos, your anxiety was just as bad as it was when you started. It didn't fix anything. It was just a Band-Aid on top that maybe reduced some of the minor symptoms, but it didn't change the problem. The second piece is rebound anxiety. We talked about the fact that these things are GABA. We use GABA to naturally calm our systems down. Oftentimes individuals who had a mild to moderate anxiety disorder, now that they're off benzodiazepines, their anxiety is through the roof. And so their problem is much worse now. So looking at signs and symptoms of benzodiazepine and hypnotic intoxication, they're drowsy, they're unsteady, blurred vision, coordination, amnesia, reduced inhibitions, and impaired judgments. So these folks are looking intoxicated. It's the same thing as alcohol. So whatever you would expect a person to look like who's been drinking, they're going to look just like that on benzodiazepines. These individuals also have amnesia, and from a productivity standpoint, it's a huge concern because there's something called, there's retrograde and anterograde amnesia. Retrograde means that I don't remember what happened. Anterograde means I'm not laying down memories. So these individuals are essentially in a blackout when they're on high doses of benzodiazepine. So they're not laying anything down. They may seem like they're on their job, they're doing their, they're doing their part at work. The reality is they're not. They're not productive whatsoever. Signs of detox of benzos are going to be anxiety, mood swings, depersonalization, high anxiety, poor concentration, low energy, disturbed sleep, and social isolation. Benzodiazepine, as I said, detoxification, like I said before, is physiologically incredibly uncomfortable. Their anxiety is going to be through the roof, and there is a possibility of your employee having a seizure if they come off of these guys. The stimulants, and I'll move through these guys fairly quickly. So these are the traditionals, Ritalin, Concerta, dextroamphetamines, the dexedrines, mixed salt amphetamines, which are the Adderalls, and then Vyvanse is a rather new medication. So this is some of the shocking data, is the number of patients who are currently diagnosed with ADD or ADHD. So the estimated prevalence in the United States is 4.4%. Looking back at the 70s until now, there's been a 1,600% increase in the diagnosis of ADHD, so off the charts. I don't think our physiology has changed. I don't think our sophistication on being able to recognize this disease has improved. I think it's overdiagnosed. Oftentimes you'll have a very brief screening tool, which at times is actually created by the pharmaceutical company. And so you're taking the 10-item checklist, and now you find that you have ADHD and you require the use of medications. A lot of this is driven, obviously, from behavioral problems as kids as well. Teachers getting very frustrated with their kids' behavioral issues, complaining to the parents dragging to the pediatrician, all of a sudden we have a kid on stimulant medication. So with respect to children being exposed at an early age, looking at kids ages 4 to 17 diagnosed with ADHD increased from 7.8% in 2003 to currently at 9.5, or almost 1 in 10 children in 2007 has been diagnosed with ADHD. Right, so this is almost a 22% increase in the diagnosis of ADHD in just the past 4 years. Once again, I don't think that we are becoming more skilled or sophisticated as diagnosticians. I think that we're just overdiagnosing patients. So how prevalent are stimulant use? 2005, doctors prescribed enough Ritalin to prescribe Ritalin 29 million times, right? That number continues to rise on a yearly basis. So this isn't a concern. Obviously, there's, and I don't want to, paint a negative picture here. There are some individuals who truly have ADHD and require these medications, and for them, this is life-saving. So I don't want to just bash everyone and say that these are overdiagnosed, or not true diagnoses. But there's a lot of people that use these medications recreationally. So oftentimes, especially in college kids, they'll say, listen, these medications are brain drugs. These are smart drugs. They increase my IQ. Things are getting better. The reality is that they only improve, if you look at the data, it's only rote learning that improves. So rote learning is that you're able to memorize lists. You're able to go through and lay down information. You're recalling it. By no means are you comprehending this. So you're not getting smarter, right? Also, individuals who use stimulants have euphoria. It's just like cocaine, just like methamphetamines. There is a huge release of norepinephrine, serotonin, dopamine at the neurosynapses, and so folks do feel euphoria. Weight loss is another reason people are on stimulants. And concerning Vyvanse was just recently approved by the FDA for binge eating disorder. So if do you guys know what a binge eating disorder is? So they eat too much on one occasion and feel bad about eating so much. They feel like they lost their control. And so now we're prescribing stimulants for this eating disorder. Okay. So some of the signs of stimulant abuse, it's going to look like, their pupils are going to look like as if they're withdrawing from opiates or as if they're on benzodiazepines. They're dilated. They're going to be hyperactive. They're going to look wired. They're going to have coordination issues. They're going to be flush, sweating, dry mouth, high blood pressure, body temperature will go up as well. So the signs of stimulant withdrawal, people crash. So if someone has had a run of either cocaine, methamphetamines, or stimulants, oftentimes we see something called hyperphagia or hypersomnia. And so in the hospital, the first 2 days, these individuals are just out. Bring me a meal and I want to sleep. And so these folks are very irritable, they're dysphoric, they're depressed, and they're just hypersomnia, sleeping the entire time. Complications of stimulant use are increased cardiac events, strokes, tachycardia, high blood pressure, etc. Okay. So now what? So I've given a lot of information about signs, symptoms of intoxication of the 3 most abused substances, classes of substances, in addition to discussing the prevalence, high number of medications that are prescribed, and sort of discussing why these medications may not be necessary to some degree, especially with the opiates. Do this many folks need to be on opiates? So part of the solution is having a really good, solid employee handbook, in addition to a solid EAP. In addition to having comprehensive coverage, I think it's really important for individuals to layer in substance abuse treatment for their plans, for their insurance plans of their employees. As I said before, 64% of folks who are dependent on substances are also employed. And so there's a good number of employees out there that are impaired. We talked about the $81 billion lost annually. It's going to be an investment if you're able to have a really strong EAP in addition to having benefits for individuals who have for substance dependence. So the question is, what do most folks think, other employees think about drug testing? The reality is most folks actually welcome it. Either they don't, if they're not a substance user, they don't care either way, or they actually welcome it. A lot of folks will welcome it because they say, listen, I don't want the guy next to me to be impaired and to me to potentially get hurt. And so I don't want folks to be concerned about offending their employees because they just need to be tested frequently. So in conclusion, just what I've discussed before in the sense that this is a very costly problem in the workplace. We need more education out there. We need staff and managers both to be recognizing for signs of for substance intoxication in addition to withdrawal as well, and to be able to have access to discuss that with HR or somebody say, listen, I'm concerned about this individual. He looks impaired. I just learned about the signs of opiate dependence, and this guy looks impaired on the job, right? Employee drug policy has to be in place, EAP, have the ability to refer to addiction providers as well, and then drug test frequently, pre-employment in addition to frequent random drug testing, because drug testing ultimately guides treatment. If someone's impaired, that's going to identify them, and we let folks know this doesn't necessarily translate to the termination, but this will get you access to treatment. Okay. That covered a lot very quickly. Okay.
Well, appreciate you coming and appreciate you doing this presentation for us, and with that, we'll go ahead and sign off, and thanks everybody out there for attending today.